Invite Dr. Manoj Prathapan for his talk on secondary pupillary block glaucomas. Dr. Manoj is consultant at Amrita Institute of Medical Sciences.
Good morning, everyone. So I'll be talking on secondary pupillary block glaucomas. It's important to identify this condition. To know about this condition, to identify it so that we can do the appropriate management. So pupillary blocks have a particular way of presentation. They are usually acute presentation. And on examination, you will see a particular configuration of the anterior chamber. You will have a exaggerated mushroom head appearance, where the peripheral anterior chamber is shallow and the central is formed, and you'll have a iris bombay in between. So causes of pupillary block could be lens, IOL, silicon oil, air, vitreous. It could be inflammatory. Let's go through various cases. The first one is a 1 week post pars plana vitrectomy with silicon oil in situ for tractional RD. There is past history of IOL surgery, cataract surgery done 3 years back. So the presenting complaint was acute onset of eye pain and decreased vision with visual acuity of CF and intraocular pressure of 60. So this is the appearance. You can see the cornea is steamy. It's a pseudophakic eye. You can see that the eye is pseudophakic, but you can see the iris bombay. So it's quite possible to have a pupillary block even in a pseudophakic eye. So understanding this, that this is possible, and we can treat appropriately. So you can see the oil reflex also. So this is possible in silicon oil filled eyes. So the mechanism I already explained. So how is the management different? So there is a limited role for mannitol because there is no vitreous to dehydrate. So pilocarpine will not work because there is 360 degrees posterior synechase, so it doesn't work. And PI also has to be done in the presence of a mid-dilated pupil and an attack. So you have to choose an area which doesn't have an iris contact. So it is usually in the mid-peripheral iris that we do the laser peripheral iridotomy. So after giving oral and topical aqueous suppressants, without the use of pilocarpine, we can do this procedure. You can see after the PA is done, the eye is much quieter, cornea is cleared. These are two other examples of silicon oil coming into the anterior chamber to cause pupillary block, but both the situations has already been treated. You can see the inferior iridotomy. This is surgical iridotomy done. If there is a risk of silicon oil escaping into the anterior chamber, the VR surgeon can choose to do an inferior surgical iridotomy. So this kind of escape can happen in weak zonules and if there is a PC rent. This another case, 65-year-old gentleman, pseudophakic for 10 years, underwent pars plana vitrectomy with silicon oil for RRD with visual acuity of 6/6. Post silicon oil removal with air exchange done 1 week back, now complains of acute onset of pain. So this is an air bubble induced acute angle closure. You can see a large air bubble filling the anterior chamber. The inferior iris is in contact with the cornea. So there is no aqueous in the anterior chamber at all. That is why the cornea is clear. There is no aqueous to hydrate the cornea. So you have air bubble and then the iris. So here the problem is that there is no space to do a laser peripheral iridotomy. Either it is iris or air. So in this situation, what can we do? So again, pilocarpine is counterproductive. You can't use it. PA cannot be done because there is no aqueous in the anterior chamber, and mannitol again will not work. So the management done here was to keep the patient supine and dilate the patient. So as the pupil dilated, the pupillary block was reverted and the AC formed. So it was as simple as that, and the cornea immediately cleared up. This is a patient was referred to us by the retinal colleagues who was referred from outside for a nucleus drop on the same day. Patient was referred to glaucoma clinic for digitally hard eye. So this patient was not amenable to the positioning, so we took up the patient for removal of the air. So when you remove the air for burping, make sure that the eye is positioned so that the air bubble comes towards the opening. So here already there is a pre-existing side port entry. Use the same side port entry to allow the air to come out, or else you can use a MVR blade or side port blade to let the air out. If it is done in the other side, you can have an iris prolapse. That is why the air has to come towards the opening site. See, as soon as the air has escaped, the patient feels much better, the eye is quiet. This is another patient who presented post small incision cataract surgery with an ACL implantation with sudden onset of pain, referred as an descended IOL. What we see here is not a descended IOL, it is a iris bombay. Inferior, you can see the iris bombay. There is no peripheral iridectomy done during surgery. So some areas the iris is pushed backwards, some areas the iris is ballooned. So this flat iris in some areas is because of the stretch offered by the haptics. So that area iris cannot move forward. But the opposite areas you will have iris bombay. So just have to do a laser PI and immediately everything is settled. The IOL is in position. Two other examples of pupillary block. One is a phacotopic glaucoma where the lens has subluxated into the anterior chamber completely post trauma. The other one is an aphakic pupillary block. Now it is not very commonly seen. This patient was aphakic for a long period of time, had a fall, and then developed a pupillary block. This is post treatment. You can see the inferior PA done, and this intact vitreous face, anterior vitreous face blocking the pupil. Next, coming to uveitic pupillary block, you can try this pupillary block is because of either occlusio pupillae or occlusio pupillae. You can have a fibrin membrane covering the pupil or 360 degrees posterior synechase. So in such situations, intense steroids and atropenizing the eye is the treatment. If it's not successful, we can do a PI. We may need to choose to do multiple PIs, and they should be larger than what we normally do because they have a tendency to fibrose. This is a patient who was post TRD surgery with silicone oil. Now present with the pupillary block glaucomas. So here pressures were very high, and the chamber showed this typical pupillary block appearance, iris bombay. This is a phakic eye. So we went ahead and did the multiple PIs. You can see 2 PIs, and suddenly the chamber is formed, and pressures also started coming down. And 2 weeks later, this again recurred like we expected. The PI fibrosed, and again the pupillary block recurred. So we knew that there is no point in further doing PI, but we did a temporary laser PI, and something has to be done. So the patient was taken for posterior synecholysis. So the way to do it is to make 2 side ports, one to irrigate, another to put your instrument. This is a cyclodialysis spatula going in and releasing the adhesions. Now you can see the AC is forming well. And this patient, again, I thought this is done, and the first 2 weeks the patient was doing fine, the IOP was normal, and the chamber was formed. But then again the patient presented with a similar condition. So again this same problem. So things are not yet over. Again there is a recurrence where the iris is that area, again there is a posterior synechia, and this has recurred. So now what to do next? So we can either choose to do a phaco with a large surgical iridectomy or a phaco trab for now. So why did I present these cases? To highlight the importance of good slit lamp examination for understanding of the mechanism of glaucoma so that appropriate care can be given. Thank you.
Thank you, Manoj, for those wonderful cases. Now, regarding silicone oil in the eye, this kind of angle closure keeps on recurring. Even if you do PI, it again, closes, and again, it's kind of it's most probably due to some amount of inflammation that's happening due to the presence of silicone oil in the posterior segment of the eye. That causes the PI to close off, and again you may have to repeat these.
There is one patient I did a the surgical iridectomy with a vitrector, and that patient did well. A large iridectomy was done.
Very large PA. You need a very large PA. Another good thing, if the patient is pseudophakic, you can do a synecholysis with the laser. With the YAG laser, you offset it anteriorly, and you hit close to the iris and the lens contact where the synechia is forming, and you do that. The synechia breaks and it reverts, but again it will again keep on coming. So you need to keep these patients on low dose steroids for quite some time. Another thing, when you're doing an ACIOL or iris claw lens, always do a PI, because you might feel on table that it is okay. There is no need of a PI. Why some amount of hyphema will be there, iritis will be more. Already a difficult case. Why do a PI? No, no. You need to do a PI because a pupillary block is going to happen. You have to, think that it will happen rather than delay a PI. In the OP, once the patient develops a very high IOP, it may be very difficult to convince the patient to do another procedure. So always do a PI in case of if you are inserting such lenses. And if you are instilling air into the anterior chamber following surgery for any reason, always make sure you put some mydriatic after the surgery, or even on table you can put some mydriatic before you close the eye. So that will also again prevent this sort of a problem from happening. Any other questions?